for an informal, intimate conversation. Dr. Carey's gonna just sort of start us off and give us an overview. And we sent her some of the questions, and I'll just moderate as needed. So Dr. Carey, thank you so much. We are so honored to have you here today.
Oh, Pam, it's my pleasure. Can you hear me okay? Okay, great. Thanks everybody. And I'm very happy to be participating in this, and I love that Komen is taking the initiative to provide this kind of information for our patients, and being a facilitator of information flow. I'll stipulate up front that what you heard there was my credentials. What you did not hear on the credentials was virologist. And we also have to recognize that this is a rapidly moving arena with information coming in, daily. And it does feel a little bit, I said last night on our faculty meeting that, there's lots of pieces to the jigsaw puzzle, and the jigsaw puzzle itself keeps changing. So like the piece that used to be fitting over there no longer does. So we have to acknowledge that. But there are a bunch of things that we do know, and I'm going to catch us up on sort of the current state. The first is to state the obvious for those who hadn't kind of been reading about it. You may remember they started talking about this as the coronavirus, but in truth, coronaviruses have been around forever, and they have been causing problems for a long time. So for example, if you think of the last 4, including this one, there have been 4 respiratory epidemics of various flavors just in the last 20 years, right? SARS was a coronavirus, right? The MERS is a coronavirus. The only one that wasn't was the H1N1, which is influenza. So what's the characteristics about coronaviruses, and the reason they seem to create these problems is that they have a tendency for they're mutable, meaning they have a high mutation rate, and they can move across species. So that's why you hear about these stories of them coming originally in bats and things like that, and then going through to another animal, and then into people. So those are the characteristics that make them a problem, and that's why there's actually been a fair amount of research in coronaviruses for quite a couple of decades now. This particular one was recognized a few months ago. They actually just characterized the genetics of it in the middle of January, so we're really in a ramped up phase. What can we say about it, and what do they know? We know that this coronavirus, compared to SARS, it's about 75% the same as SARS, but that 25% that's different genetically is the reason why you can't just use the same approach that you could use in SARS, or people who had SARS are not necessarily protected from getting this one. And that's one of the features of these sorts of diseases. It causes a largely lower respiratory problem, and the reason for that is because of the receptor that it grabs onto, and where it causes its problems is in cells in the lower respiratory system. And that's also why you see a greater problem in older patients than you do in younger patients, which has been a consistent finding. A couple of things about this one that might be a little bit different from the other ones. It has maybe a longer incubation period, maybe up to 14 days or so, which is why you're hearing people talking about isolating for 2 weeks. It is a little more infectious than SARS probably, but remember, infectivity and your likelihood of passing a disease from one person to another. You've heard this word either R0 or R0. I don't know if you've been hearing that term. It's R and then a 0 after it. That is a measure that's used of, in a given infection, how likely is it to be passed on to other people? And of course, if you think about it, that sort of depends on like the nature of where you live and how many people are around you. It's going to be very low if you live, and if you're all by yourself on an island, your R0 is going to be 0, or I guess 1, because you count as 1. This one looks like it's similar to SARS, which is not as infectious as, say, measles. Measles is the most wildly infectious thing there is, but it's enough that it's causing all of these problems. And partly because you can spread it when asymptomatic. And those are some of the things that have come out of the experience in China and places like that. The Currently, we don't have treatment for it. It's really supportive treatment, although there's a huge amount of effort going on and there's a lot of things that are starting to come out. So it wouldn't surprise me within a few months we did have some treatments for it. At the moment, this is, as you all know, it's a worldwide pandemic, and here in North Carolina, we're in the kind of the going up phase. The things that are encouraging is that when people have been when there's been effective public health measures, you actually can shut down the transmission of the virus, which is how you control it. And so all of these efforts that you're hearing about with shelter in place and things like that are all around cutting down the transmission rate, which is how you also can effectively take care of the patients better. As you've been hearing, if there's a explosion of infections, one of the big problems is that you can't take care of the patients because you outstrip your healthcare resources. If you can control the transmission, one of the biggest improvements that comes in outcome is simply because you have more healthcare resources to deploy. Most of the transmission of this virus is through close contact. You can have droplet, which is why they say, 6 feet apart and things like that. It's probably not so much airborne. Um, uh, and most people have mild, moderate, or asymptomatic disease. I mean, that's one of the natural history things. About 10 to 15% can become more severely symptomatic. And as you know, there are, unfortunately, about 5% can become really severe. And that's the ones that need the healthcare system resources and ICUs and things like that. So let's talk about risk factors for getting COVID-19. So the CDC, and if you're interested, please, go to the CDC website. They keep it updated. ASCO actually has quite a bit of information on its website, and it has links to CDC, and they do keep updating these. But if we think about, as of right now, the known risk factors are age, and it's very unusual for particularly severe disease to happen in the very young. The risk factors for not just getting it, but having a symptomatic form of it is age, immunosuppression, and that's pretty much it. They recommend a careful attention to management and extra efforts at isolation and things in pregnant and lactating women, but they don't really know if there's any particular that's a risk factor or simply practical advice for people who are pregnant. So what does it mean? And I think one of the questions that came in last night was, what does it mean to be immunosuppressed? So that's actually some technical terms around what they consider to be high-level immunosuppression, which is, there are some primary immunodeficiency disorders. Receiving cancer chemotherapy is considered high-level immunosuppression. If you take steroids, like the equivalent of 20 milligrams a day of prednisone, that's considered high-level immunosuppression, and there's a few other things like that. Lower level is basically everything else, and as you know, there's a number of breast cancer drugs that can cause a low level of immunosuppression, and so it's reasonable to be careful, although just consider it's not the same as a person who's had a kidney transplant. So what are the recommendations for people at high risk, which is basically, first off, try not to get sick in the first place, which is, of course, the fundamental. Try to, this is where sheltering at home. So try and stay away from other people. Try to be home as much as possible. Try to limit going out into crowds. If you go out into public, try and limit close contact. Excuse me. And wash your hands frequently. And we'll talk about washing your hands in just a second. And so basically it's what we call social distancing now. I think one of the things that you can try to do is, if you're on medications, see if you can get extra medications. Many of the payers are actually allowing additional, not just 1 month supplies, but additional months of supplies to stock up, so you're not having to go to the pharmacy as often. You can use mail order for your medications and work with your providers about these. Make sure you have enough tissues and things at home as much as possible so that you don't have to go out as much as you might normally. When we say wash your hands often, that means soap and water, 20 seconds. So when people say wash your hands, it's warm water, it's soap, and it's 20 seconds, which is a lot longer than people sometimes think. So it's more like what a surgeon does, although they do it for even longer than that. But think about really washing your hands and making sure you get between the fingers and under your rings and things like that. That's particularly after you've been in a public place. If you had to get on an elevator and push the elevator button, when you get off, go to the bathroom and wash your hands. Or carry something like paper towels or something so you don't have to press on buttons. If you touch your face, you should wash your hands, right? These are the sorts of things, because the transmission really goes through mucosal surfaces. So eyes, nose, mouth are the classic ones. If soap and water aren't possible, then hand sanitizers, and the ones that are, they say you need to have at least 60% alcohol, which all the Purells and things like that do, but it's 60% alcohol containing hand sanitizer. That's preferred less than soap and water, which is thought to be a better system, but it's pretty good. Try not touching high touch surfaces. So, I mentioned door handles and things like that. If you do have to do those, and certainly don't shake hands. None of us do that anymore. We're doing the elbow bump, but just keep in mind there's a reason for that. If you have to touch something, try to not do it with your hands, or wash your hands right away after that. Try not to touch your face, your nose, your eyes, right? Your mouth. Try not to do those things. It's very interesting. If you actually start to try not to do that, you will realize how often you actually do that. It's really common for people to touch their face, so minimize that as much as possible. It's also true that you're in your home, so make your home as clean and as disinfected as possible. Routinely clean off your frequently touched surfaces, like your tables, like your doorknobs, things like that. And then, of course, the obvious is stay away from travel as much as possible. So what is ASCO saying about cancer patients? So having cancer is a risk factor for having a worse outcome, although to be honest, it's only about twice. It looks like the most recent data as likely. It's still less than 10% of people in terms of fatality rates, where 3% is the overall in the populations. Those numbers, I'm giving you numbers more as comparators, but realize that the numbers are actually really hard to get. And those are probably overestimates because we don't really know how many people in the population are infected. So if you only know about the people who are getting sick, then your numbers will look worse than if you know about everybody. So, but in truth, cardiovascular disease, diabetes, hypertension, chronic respiratory disease, there's a whole lot of other risk factors that are worse than having a cancer diagnosis or cancer history. Now, in the metastatic setting, it depends to a large degree on what kind of treatments you're on, and that's a separate issue. It's not a one size fits all. As we all know, our metastatic breast cancer patients, you guys are not a one size fits all population, so we have to be thoughtful on a case-by-case basis. So what is ASCO saying about cancer patients and our approaches to therapy? And if you look, they have guidelines on the ASCO website, and they keep updating them. And ASCO is doing a lot of work in also trying to do analytics around this to try and figure out what exactly the experience is through their cancer link function, which is a big population-based big data effort, to figure out what the experiences are. And we don't really know the answer yet, but keep waiting because it's coming. Essentially, it's be thoughtful about what therapy patients are on. If a patient is on maintenance therapy and it's reasonable to take a hiatus, particularly if they're on chemo, it's totally reasonable to do so. You just have to consider the risk-benefit ratio. If a patient has unstable cancer, then it's probably not a good idea to stop their therapy. A second option is to go from IV to oral therapy, so you can minimize the number of times they have to come into the hospital. And really, this is all about what's the indication for the therapy, what's the goals of care, and it's really centered on chemotherapy. if you're in a place where there is an outbreak and your particular cancer center or your particular hospital has a lot of cases, another option is to try and pursue being treated elsewhere. That's a conversation with your healthcare provider, and I can promise you they are having these conversations internally already. And I think that's probably that's a summary of the ASCO guidelines, but that's a pretty reasonable one. So what about some of the other questions? And I'm grouping a few that came in that were sort of similar. The first is what's happening at my own institution? And in particular, what are we doing about breast cancer patients who are not on trial, and also those who are on clinical trials? And so UNC, the North Carolina Cancer Hospital, and Lineberger Comprehensive Cancer Center we have a particular approach. Actually, several weeks ago, we started screening patients before they come. So the night before, they get a call that asks whether they have any respiratory symptoms, any fevers, et cetera, if they've had any known exposures. And that helps us triage who comes in. We also have essentially eliminated what we consider non-essential visits. So survivorship visits have been delayed for 3 months. Things that are more or less routine in a well patient. Because at that point, the risk-benefit ratio really tips in favor of not exposing the patient to our hospital and to other people and the crowds that by definition are present in a hospital setting. We've limited that. We've spread out our admission kiosks. We do a lot of online remote check-in, and we've spread people out as much as possible. And we have triage points for identifying patients who are having symptoms at multiple points during the course of patients coming in. That's our regular care. We've spread our infusion center chairs, et cetera, et cetera. The trials, and I have the pleasure of being part of a couple of kind of blogs about this from cancer center leaders around the country. And I think we're in the majority in the way we're handling trials. And this is basically how the NCI is recommending. And we don't want to shut down clinical trials because these are sometimes very important for patients. So sometimes a trial is enormously important for the health and well-being of that patient. If the patient is benefiting from a novel drug given in the setting of a trial, stopping the trial is not in that patient's best interest, and there's no interest in doing that. You have to do it as safely as possible, and there's a whole bunch of guidelines that have come out from the NCI and from the governing body called CTEP that center on what can you minimize in terms of risk to the patient, but still allow them to have the benefit of the trial. And minimizing means sometimes we have converted a whole bunch of the things that are normally done in person, but could be done virtually, to be done over the phone. And there's a number of study-related or protocol-related elements that might be done that way. Another thing that we're doing is some of the consenting can be done over the phone. And that takes going through your IRB and an approval process, but it is perfectly fine to do so. Shipping investigational drugs. We normally are not allowed to ship investigational drugs. That rule has been relaxed. The FDA is on board with this. And so trying to minimize having patients only come in for the things that are actually required for them to come in person, and minimizing their exposure to the healthcare system while still remaining safe on their trial. The second category of trials that are allowed, so category one being clearly trials that are in to the benefit of the patient's own health and well-being. Category two are trials that are scientifically important, and the trial procedures are being done at the same time as a regular procedure. And so there's also been a lot of relaxing of study-specific protocols and procedures, eliminating them or omitting them for the time being, so that the trial can go on as long as you would be there anyway, and the trial is part of your normal care. And there's no additional visits, there's no additional burden on the patient to performing the trials. And that's Lineberger is similar to others. We adopted that approach a couple of weeks ago and have been continuing. And I think the last poll I saw, I think out of 16 cancer centers, about 13 of them had that particular approach. A couple of questions came in that related to specific breast cancer drugs. Endocrine therapy itself, and I think there were questions about exemestane, about anastrozole, about letrozole, and about fulvestrant. Those are not immunosuppressive. The underlying having metastatic cancer may be to a degree an immune compromised situation, but not to a high degree, and those drugs do not add significantly to that. Now, CDK4/6 inhibitors, if those of you who are on palbociclib, ribociclib, or abemaciclib, those can be, not to a large degree, not like cytotoxic chemotherapy. And even within chemotherapy, some are worse than others in terms of immunosuppressant, but a little bit so. And there's also some of these drugs can have a pneumonitis, what we call pneumonitis, or inflammation of the lungs, that can confuse things in this setting. So while it's not mandated to hold or stop these drugs, it's also not unreasonable to hold or stop them for a little while, particularly if your neutrophil count tends to run low on them. I think that's a case-by-case situation. Chemotherapy for our patients is ongoing. We have tried to move to treatments that have a schedule that requires less frequent visits. Chemotherapy is itself immunosuppressive, as I mentioned on the earlier slide, and the same restrictions or recommendations are just enforced a little bit more for patients who are immune suppressed about not going out. Somebody asked about masks. I think if you have access to masks and you have to go to a public place, it's not an unreasonable thing to wear. Just recognize that most of the transmission of this virus is actually through what are called fomites. It's handling things. So it's more what you touch, less somebody coughing on you, although that obviously is a risk factor. There were a couple of questions about the specifics of individual kinds of breast cancer. HER2 positive, triple negative, hormone receptor positive, those diseases themselves don't necessarily alter the risk so much. It's more what treatments people are on. Another question that came in had to do, or a couple of questions had to do, related to, as I mentioned, about therapy from a medical standpoint. There are, at the same time, and there's actually some guidance coming out from the American Society of Breast Surgeons. They are also trying to delay surgeries whenever it's possible, and to minimize surgery as much as possible. To be honest, the minimizing part they were already doing. Our surgeons have been very proactive for decades now about trying to minimize surgical procedures. It's really more about delaying. In newly diagnosed patients, we are sometimes putting them on neoadjuvant endocrine therapy, for example, in order to buy some time before the patient has to go to surgery. I think that's a reasonable thing. We're doing it on a case-by-case basis, and this is a discussion that's happening weekly for our newly diagnosed patients. Similarly, radiation schedules that allow fewer visits might be appropriate, or delaying within a window. It's all about delay is okay as long as it doesn't put the patient at added risk of the cancer. So I think you have to decide what the risk of the cancer is and kind of where the windows are. In many cases, adjuvant therapy can be delayed for a few weeks, and we know that it doesn't start to have a deleterious impact on outcome for several weeks. And I think those were the main topics that I wanted to make sure that I covered up front. And then I think we were going to do the rest of this. So we're about halfway into it, and do the rest as questions, if that's.
Carey, we have a lot of questions,
Okay.
as you might imagine, but one of which is lots of people saying, I'm 6 months out, I'm a year out from chemo radiation. Am I immunosuppressed? And then along with that, so that's the recent treatment, finished treatment. Then we had several questions. I'm 5 years out, I'm 10 years out, successful treatment, good mammograms, all is good. Am I immunosuppressed? Am I at risk? Is there something different?
Let me do those one at a time, because I'm not smart enough to remember multiple questions. So question number one was, how long am I suppressed after chemo? That's a more complicated question than it sounds. So there were some studies done that looked at the adaptive immune response parameters, like scientifically looked at the immune system after chemo. And it looked like even when you got out to 9 months or so after chemo, there was still some alterations. However, it wasn't clear that those alterations were enough to actually cause you to be prone to infection. They were just persistent alterations, and they could not answer the question about whether that persistence, you know, meaning they could still see the impact, but they didn't necessarily, it wasn't to the degree as during chemo. But you can say that the immune system, even up to 9 months after chemo, is still a little different than it was before you took chemotherapy. I personally would say would be a low level immunosuppression, but something to keep in mind.
So the second part of that was, if I'm 5 years out, 8 years out, have
Mhm.
had, surgery, radiation, chemo, my
Yeah.
mammograms have all been good, am I at risk? Am I different somehow than the population because I've had breast cancer? Is what
No, not that we know of. Not that we know of. I think in that survivorship group, as far as we know, that they tend to behave similarly, and that is the group, in fact, that we are deferring the visits for 3 months because they're at risk for getting COVID-19 more than their history of cancer many years before would put them at risk of anything else, and their cancer risk is low enough that it's worth delaying and deferring the clinical visit and their breast imaging.
Krista, what other questions have you gotten live?
Okay, kind of similar to what you were just speaking on, someone has wanted to hear how radiation may play a part into treatment. You've spoken to chemotherapy, but again, if someone's had radiation, are they at higher risk of complication if they were to contract COVID?
There's a theoretical thing. So some people who have had radiation to the chest area have actual toxicity. They have radiation, what's called radiation pneumonitis. And you can have some, in rare instances, that can be a long-lasting damage to the lungs. That's really pretty uncommon. You can see some patchy scarring on imaging sometimes in patients who have had radiation. I don't know that anyone knows whether or not that itself creates any increased risk. It's not the same as what we would consider chronic respiratory disease if it's asymptomatic and can only be seen on a CAT scan, for example. So I think there's some range of reality there, but in general, probably not, particularly if you are a person with apparently normal function, you're able to walk, run, do your thing, and you're out from your radiation. I think the only caveat in there are people who actually have radiation pneumonitis or people who have had a greater degree of scarring than the norm.
So there are lots of questions about endocrine therapy.
Mm-hmm.
So people who are on their endocrine therapy for 5 or 10 years, what is their risk, and what I know you've sort of talked about that, but we keep getting the question. So let's be specific.
Risk of COVID-19 or risk of breast cancer?
Risk of COVID-19 and what they...
I'm not aware of any data that suggests that they're at higher risk of getting COVID-19. And the endocrine therapy, it's hard for me to invoke a reason biologically for the endocrine therapy itself to be creating a particular propensity there. If there's anything, it's pretty mild.
Okay, so there are, again, lots of questions coming in. So let me see if I can keep up with the ones that came in first that you haven't spoken to already. So there was one question that the information you started sharing about patients and how to take care of themselves, would you say that that covers all cancers in general or just breast cancer?
No, I think that's generalizable. In fact, The greater risk is in people with hematologic malignancies who tend to take drugs that have a bigger impact on the immune system because those are the cells that are actually the cancerous ones. So I think breast cancer is just one part of this, but I think that is reflective of recommendations that ASCO is putting out for patients with cancer in general.
There's also another question about port flushes. Are there any concerns in particular that patients with ports should be concerned about?
Regarding getting COVID-19, no, not particularly.
And we have someone calling in from, I believe, Pink Blue in Nigeria. And one of the questions there is, can people get COVID through body openings like skin openings?
So typically it's not thought to be transmitted through intact skin. It is mucosal surfaces is the main way that it gets transmitted. So intact skin is not, as far as I know, a way that it gets transmitted. That said, if you touch skin and it can be on skin, and if you touch the skin and then you touch your face, your nose, your whatever, then that's why. So touching skin, you should wash your hands.
So there's a question about the CDKs being more at risk. I think the question is, can you give us on a scale? You mentioned that different chemo agents are higher risk than others. You mentioned CDK4/8 being OPPS. I'm not sure what that, being lower on the scale, for example.
Yeah, I mean, I think it's less about, you mean, which ones? Obviously certain CDK4/6 inhibitors have, they all as a class can affect the neutrophil count and the white cell count. Some of them affect them a little bit more, and some a little bit less. But in truth, it's a pretty patient-specific phenomenon. Some patients have trouble with their neutrophil counts, and others just don't. So I think this is why I said it's really a case-by-case thing. If you're a patient who's on has stable, controlled metastatic disease on a CDK4/6 inhibitor, and your neutrophil count is normal, I don't know of a compelling reason that you have to stop or hold it. On the other hand, if you're one of those patients that we all have where there's frequent adjustments going on to the CDK4/6 inhibitor dose, that might be somebody where the risk benefit ratio is in favor of stopping it for a month or two while the COVID-19 dust settles. Given that many of these patients are on for months and months and months or years and years. And so I think, it's really you have to decide what are your goals, how are you tolerating it, and what's the risk. So a patient who runs with a chronically low neutrophil count, that they're going to be a little more immunosuppressed than somebody whose neutrophil count is normal.
So there's some questions about caregivers and if you're in treatment or you're metastatic and have low white blood count, and the caregiver is bringing their children, should they be bringing children, or should grandparents who are sick stay away from their grandkids and that kind of thing?
There's a lot to unpack in that question. Children are not themselves, they're not at risk, particularly for getting COVID-19. If they get it, they tend to have a pretty mild form of it. However, children are terrible at social distancing, right? Like they just are. I have 3 kids. They're terrible, right? They're always touching things. They're always touching each other. They're whatever. So it is, they are more likely to, kind of have these kind of exposures. And so I think there's some risk to that. I think older people, just by virtue of being older, are at higher risk of having a complication of COVID-19. And clearly the case fatality rate for people who are in their 70s and 80s is much, much higher than it is in younger people. And so I think being more proactive about limiting exposures to other people is important for all of us. And it's particularly important in that kind of setting. So I think probably small children where you don't know where they've been or what they've been doing coming into your house, I'd probably not encourage that for all the reasons I just outlined.
So several questions about people. Oh, sorry, Krista. I'll stop. Go ahead.
I was just going to say there was a follow up to that. So what about the parents of the children that may, want to see the mom or someone who is living with or going through treatment with breast cancer?
You're going to have to, play this by ear. I have to say, I have a 93-year-old father, and, he and I are doing this remotely. I was supposed to go up and see him next week. I'm not going up there. And it's not that I've had any particular exposure, although tomorrow I'll be in clinic seeing patients. And so one never knows. And I would hate to introduce something to him inadvertently. That's a real issue. It's a real issue. There is an asymptomatic phase. And we just don't know when viral shedding actually starts. So I would say, of course, if you need to bring groceries and you need to do things that are important, but just keep in mind that all of the things being equal, a Zoom cocktail hour is really pretty good and a lot safer than an in-person visit. And that's how I would think of it.
We've had several questions about people whose breast cancer has been affected their lungs. Are they at more risk?
So chronic lung disease is probably, again, these are everything we have right now are what we call case series, right? There's no huge database of information, but the series that exists from China and from Seattle and other places that have reported this suggests that underlying lung disease is itself a risk factor for getting a more severe kind of version of COVID-19. I can't imagine that if the underlying lung disease is from cancer, it's any different than if the underlying lung disease is from something else. So I think being very particularly attentive to all the things we've been talking about would be particularly important for somebody with any kind of underlying lung disease.
Krista, did you have one?
Yeah, so I have a couple. So there's one that came in. If you are living with MBC and waiting on COVID test results, what should you watch for?
The symptoms are really lower respiratory ones. So fever is one, but you can have the disease and not have a fever. Cough was a classic one. Fatigue. It's basically like the flu in many regards. And so you should be looking for that. I think if you're waiting for testing results, you should be particularly aggressive about social distancing. Put off going to the grocery store if you can.
Okay, so next question is, could you give your thoughts around for someone having recently finished chemo and is in the window of needing surgery within the next couple of weeks? What are the risks of postponing versus going forward before the peak of cases in North Carolina?
So at UNC, post neoadjuvant patients, and this is actually true in the emerging national guidelines that are coming up from the American Society of Breast Surgeons, are prioritized, meaning that they are done within a month of they're sort of a window for getting them done. I think that's important because you still have the cancer in place, and so post neoadjuvant should be prioritized, and I would try and get through that.
We've had several questions about, as you can imagine, anxiety that we who are survivors or in treatment or living with metastatic breast cancer already are anxious, right? do you have thoughts about how to deal with that anxiety so that we're not calling you every day with every symptom, but also we know that we must pay attention? And just before you answer that, we are working on putting together a program like this with therapists and patient support teams specifically around that. But, we at Komen are now saying for women who had, or men who have had breast cancer, if you feel something that's unusual, pain or whatever, for 2 weeks, call someone, call your doctor. So pay attention. What do you think about, what are some of your thoughts about managing our anxiety during this time?
I think you hit the key thing. I mean, as in most settings, knowledge is not only power, but it's also reassuring. So I think what's the scariest thing is a feeling of uncertainty, and that you don't have a handle on the truth and the reality of the situation. So I think organizations like Komen, being proactive about providing resources for patients to tap into is going to be hugely important. I think institutions are doing this also. So, we're instituting, kind of phone contacts with patients from the healthcare providers, just to reassure them, but let them know what's going on. As I mentioned, a number of the national organizations have patient-facing parts of their websites with specific information and links to providing, like, how do you know if you're at risk? How do you handle exposures? Things like that. The CDC is one, ASCO is another. I think those are two of the particularly reputable ones that provide specific information for cancer patients. And I think, otherwise, I think whatever mechanism you have in your community for addressing anxiety and these sorts of problems, it's not at all surprising. We have a psycho-oncology program at UNC, and that's for the patients. And it reflects the fact that cancer patients have their own unique reasons for anxiety and stress, and this isn't making it any less. So I think I would try and use those community services as much as possible also.
So we have lots of people asking about their specific situation. So I'm going to avoid addressing that. But several of them are on multiple chemo, are either in clinical trials or on multiple chemo, taking steroids as well for some side effects, and are pretty severely immunosuppressed.
Mm-hmm.
Is there anything that they should be doing beyond what you've said earlier about washing hands and isolating, and obviously having a conversation with their doctor about whether they should go off any of those, and your risk benefit analysis? Is there anything else for folks who they know they're immunosuppressed and they're in treatment?
I think I tried to cover the things that we know can be effective or that we believe are effective. I'm not aware of any other things that can be done. There aren't any treatments, for example, that we know can help prevent, the acquisition of COVID-19, unfortunately. But there's a lot of research going on right now, a lot of trials going on, so hopefully there'll be something. And I suspect that when there is something that they find is effective, the people who will be, approached first would be those who are at higher risk of a complication of COVID-19, and that would be immune suppressed patients and elderly.
So this is a hard question, especially since we just talked about anxiety, but we're getting the question, if hospitals get overrun, are those of us who are living with MBC, how will we be triaged? And and the quote is, will we be put at the bottom of the list?
No. I think that is a hard question, in part because, we don't actually know how this is going to play out. And I think, you're reflecting the anxiety that's out there now everywhere about what happens if we outstrip the, ventilators that we have available. I think the key part of that is you won't outstrip the ventilators if, in fact, we blunt the transmission rate. And I don't know how that will play. I honestly can't answer that. No, I don't imagine that a metastatic breast cancer patient, simply by virtue of having metastatic breast cancer, is going to be put on the bottom of any list. But I don't know exactly how this is going to play out.
Krista, do you have others?
Yes, there's two more that have come in. So one is, do you have any treatment tips if someone were to get COVID-19? This particular individual has heard no ibuprofen, use salt, water, vinegar rinses. Are these accurate?
I'm not aware of any particular recommendations like that.
And the other question that came in is, do you know if there's any tracking being done with those with breast cancer who are getting COVID?
Well, that was what I was mentioning earlier. So there's a bunch of initiatives that have been kicked off.
Okay.
ASCO is leading one through its Cancer Link effort. There's actually a number of people who are trying to create a registry. It's actually, you need to create these things, and they're probably going to have to leverage existing resources for places where patient data are already being collected. But yes, the short answer is absolutely.
Okay.
Which is where we'll get better information about what exactly is the experience for patients with different therapies, with different, at different points in their treatment time frame, et cetera, et cetera. I mean, getting information, has to come from these big data initiatives. And I just saw a bunch of emails flying around from ASCO that's taking a leadership role in this. Not surprisingly, because they have a big data initiative already.
And there is one last follow-up question about ports. So for those who do have ports, can they still get ports flushed on a regular basis? And if not, will that cause issues?
I think port flushes, oftentimes can be delayed. And I think it's perfectly reasonable to avoid a visit just to have your port flushed if you can put it off for a month or two. And that's probably what most people are doing. They're putting it out to 12 weeks or whatever. I don't know that there's a reason that if you're going to be there, getting your port flushed is, an appropriate thing to do. Again, in the risk-benefit ratio, it's probably a good thing to keep your port from getting infected or clotted.
One other question that I've seen a couple of times is lymphedema. Is that anything we need to know about lymphedema? Does the fluid retention put you more at risk? Is there anything to?
Not particularly. Lymphedema, of course, confers additional risk of infection in the affected area, but not necessarily for a respiratory illness.
Krista?
Okay. This is from an RN who actually finished treatment in 2017 and was tested and found that she had no immunity to measles or rubella. So she's just concerned here how much immune systems are suppressed and the lasting effects. And are the risks greater than we actually know?
The risks of
COVID.
So there's no, unfortunately, having had other viral illnesses or vaccinations does not confer any known resistance to COVID-19. It's a novel virus. So, so it's really not a question of what you've been through before and whether you have lost immunity to other things that you would expect to be immune to, including old coronaviruses. This one is unfortunately too novel. Your immune system doesn't recognize it already, so it's really new to everybody. So that's the best answer I can come up with for that one.
Okay, I'm going to ask one last question that came in, and then we will wrap up. So this last one is for those of us who have just come out of surgery, breast surgery, is there a higher risk of contracting?
Not that I can think of a reason for. No.
Okay. Well, great. Well, we've had over 100 people at our highest peak on today's call. So we're just so thrilled that we could do this. Thank you so much, Dr. Carey, for your time and being able to, spend the lunch hour from our various remote locations to really, even those in Nigeria have joined us, which is super exciting for our affiliate. To know that we've been able to reach beyond our country with this information, and that there's many concerned for patients who are living and in treatment with breast cancer, that this is relevant. I just want to say again, that we do have our treatment assistance program. We have the 1-877-GO-KOMEN breast care helpline that's available. And again, we do have a monthly metastatic breast cancer support group that will go virtual during this time. I've gotten there's been a couple questions about resources and access to resources. We have just launched a page on our website yesterday for some COVID specific information as it can relate to breast cancer, as much as we know what resources are being put out from national, as well as what types of programs we can support folks with here locally across the state. So please check back to our websites, keep in touch with us on social and Facebook, Twitter, Instagram. We will try to give out information as we know it as quickly as possible. And just want to thank everyone again. Pam, is there anything you or Dr. Carey would like to say before we get off?
Just to remind everyone that our Race for the Cure, which raises funds for research and the treatment assistance program, et cetera, has been rescheduled for September 12th. You'll be seeing lots of information about that as we go forward.
No, and I just say, stay home and stay safe, everybody.
Thank you so much, Dr. Carey. This really means so much to us.
Yes. Well, thanks everyone. Take good care. Know that Komen NCTC is here for you, and we'll see you soon. Okay. Goodbye.
Bye.